Hello, and welcome to Activ Doctors Online's November webinar, Understanding Alzheimer's. Alzheimer's is a progressive, degenerative brain disease that destroys memory and other important mental functions. Worldwide, 47 million people are living with Alzheimer's, and it is estimated that that number includes as many as 5.3 million Americans of all ages. Since 1983, November has been dedicated to raising awareness for Alzheimer's. This webinar is a part of our efforts to support this cause. Joining us today is Clinical Assistant Professor from Georgetown University and Activ Doctors Online Medical Director, Dr. Howard Zahalsky. Dr. Zahalsky, welcome.
Thank you very much, Caitlin. And I am very happy today to be talking about Alzheimer's and dementia. Unfortunately, Alzheimer's affects too many people in the United States. Before I go on, I'm going to be using the word dementia a lot. In non-medical circles, when you think of dementia, you think of demented and somehow dirty or even sexually inappropriate. For doctors, dementia and memory loss are used completely interchangeably. They're synonymous. So anytime you hear me talk about dementia, it is no different than memory loss. Alzheimer's is a subset of dementia. We usually refer to it among ourselves, among doctors, as SDAT, or senile dementia Alzheimer's type. Alzheimer's is the leading cause of nursing home admissions. Most people in nursing homes and even in assisted living are there because they have at least some degree of dementia. The medical health care dollar analysis shows that 50% of all health care dollars are spent in someone's life in the last 6 months of life. Most of these dollars are spent because of dementia. Yes, people have heart disease. Yes, people have strokes. People even have cancer. But what really runs up the medical costs is dementia, which require a lot of attention, a lot of assistance, living in institutional settings, as opposed to drugs or doctor's visits. It's those kind of expenses, the actual day-to-day, hour-by-hour caring of someone with dementia, that is really responsible for a disproportionate amount of healthcare expenditures in the United States and abroad. But so far, we really don't have too much that we can do about dementia. But going forward, we're going to discuss how to identify dementia, how to maybe catch it early, and what things we do have available to maximize an elderly person's mental acuity. So let's go on to the next slide. Here you see a delightful geriatric older woman who may likely have dementia, and you see a delightful, healthy younger woman behind her. The point of this slide is actually not the elderly woman. It's the woman in the background who is most often the patient's daughter or granddaughter. The daughter or granddaughter, or the family in general, are usually surprisingly the last to know when someone is developing dementia. Why is that? Because long-term memory is the last thing that someone loses when they're getting dementia, particularly Alzheimer's dementia. So when the daughter comes over, she's going to remember her favorite toy from when she was a kid. She's going to remember her daughter's favorite color. She's going to remember where they lived 29 years ago, but she may not remember what she had for breakfast. Now, a lot of times I can't remember what I had for breakfast, but her short-term memory is going to be the problem. And a lot of times the family isn't quizzing them regularly on what date is it, what day of the week is it. And they also assume that because mom or dad might not be doing too much as they get older and have other medical problems, they may be sitting around the house more. So they come up with excuses such as, well, they just don't read the newspaper anymore because they have cataract, so how are they going to know what the exact date is? Or mom or dad wears hearing aids, and sometimes they just can't hear very well, so the fact that they don't remember what I just told them 10 minutes ago was probably a hearing problem, not a memory problem. So by the time that they get identified as having dementia, oftentimes it's more advanced than it has to be, because the family has either been oblivious to the fact that the short-term memory is going, or I've seen in many cases just living in denial that there's actually a memory problem that their elderly relative is dealing with. So, on a regular health visit, whether it be maybe for high blood pressure or high cholesterol, or maybe even brought in by the family because they are noticing some memory problems, how is the doctor going to identify them as having memory loss or dementia? And on the next slide, you can see the test that I do on a regular basis. This is called the Mini Mental Status Exam. It's a 30-point questionnaire, and it goes through all sorts of different types of memory issues. There are some questions that are a lot more important than others. Some of the questions are really simple. Where are you right now? What's today's date? What day of the week it is? The most important questions are the short-term memory test. So I'm going to do a mini mental exam on you right now. I'm going to give you 3 things to remember, and I want you to pay very careful attention because I'm going to ask you about them later. The 3 things are pen, eraser, and the color blue. Now remember those because I am going to ask them later. At the end of the test, you score it, and you get a score between 0 and 30. Anything under 27 is at least a small amount of memory loss or dementia. Most of the questions are actually really easy, so you say, oh my God, you got to get at least a 90%. I haven't gotten a 90% on a test since elementary school. Now, this is a test that if you don't have any dementia, you pass with flying colors. Now, what are the warning signs that as the son or daughter or grandson or granddaughter of someone with dementia that you should be looking for when you're worried that your elderly relative might have memory loss? And on the next slide, we'll see a checkbook. A lot of times when I diagnose someone with dementia, it's met with resistance. Again, the family is in denial a lot of the time. No, mom doesn't have any memory loss. She can remember who was president in 1963. Mom's doing just fine. She just has bad hearing. And then I say, well, who's paying mom's bills? I say, oh, well, I've been doing that for 3 years because she just too much for her these days. That's when they started to get dementia. It's a good measuring stick of when someone's mental acuity is starting to go when the family doesn't feel that they're capable of paying their own bills anymore. So when you take the checkbook away from mom and dad, whether you recognize it or not, that's when the dementia is likely starting or likely started. Now today we're talking about Alzheimer's awareness, and there are actually several different types of dementia. Robin Williams, who died recently, was said to have early Lewy body dementia. There is dementia that you can get, or memory loss that you can get, because you have multiple small strokes. Even if you don't have signs of a large stroke, it's what's called multi-infarct dementia. If you have Parkinson's disease, advanced Parkinson's disease can come with some dementia. Alzheimer's is a little bit different. Each of these dementias has their own list of other symptoms that goes with it. But in Alzheimer's, you have a specific problem, which is a decline in executive function. What, Dr. Zahalsky, is executive function? Executive function is forgetting how to do tasks that are almost not even memory related. A great example is buttoning your shirt. Most people have a way that they button their shirt, either from top to bottom, or some people button from bottom to top. Someone who has Alzheimer's will have trouble buttoning their shirt. Again, a lot of times families live in denial and they'll blame it on arthritis, but they'll go from the first button to the 4th button to the 5th button back to the 2nd button. You lose the ability to organize tasks, even very simple tasks that a 4-year-old can do, in your brain, and things just seem to get disorganized in addition to memory loss. This is a classic sign that the type of memory loss you have is Alzheimer's as opposed to one of the other dementias that we were talking about. So your family's worried about you, or your doctor notices something. You go to the doctor, they do the mental status exam, and you don't score very well. The doctor believes that you might have Alzheimer's. Is there any additional testing that can be done? Well, one test that gets done not infrequently is a CAT scan of the brain. To be honest, there is nothing on a CAT scan of the brain that can scream Alzheimer's, But on the next slide, we'll see the difference between an Alzheimer's brain CAT scan and a quote-unquote healthy or normal brain. As you can see on the left, on the normal brain, the brain kind of looks plump and healthy, like a big fat turkey. There are little holes in the brain. These are areas where the cerebrospinal fluid, or CSF, is made. They're called ventricles. They're towards the middle of the brain. It kind of looks like almost a blackish Y right in the center of the screen. But everything basically looks kind of squished together. If you look on the right, you're losing that squished together. You can tell that that's a less thick, less juicy. If it was an orange, you'd want the orange on the left, not the orange on the right. Those holes in the brain, those ventricles, they are now bigger and more wide open. It's not that the ventricles have gotten bigger, it's that the brain tissue around it has deteriorated, kind of pulling open the ventricles and creating more empty space in the brain. What you're not seeing on this brain, the Alzheimer's brain, is any focal damage. If, for instance, the patient had multi-infarct dementia, you might see some additional big black spots in various places in the brain that indicate a stroke. There are other classic findings, for instance, in the Lewy body dementia I talked about. There might be little white specks throughout the brain, which are these Lewy bodies that I could do a whole nother lecture on, but today we're talking about Alzheimer's. The typical Alzheimer's brain just looks thin and weak and tired compared to a strong, healthy-looking normal brain. So, you have an elderly relative who's losing their memory. They're losing their executive function. They didn't do very well on the mini mental status exam. And you do a CAT scan of the brain, and you don't find Lewy bodies, and you don't find strokes. And your doctor says, I think they have SDAT. I think they have Alzheimer's. What are you going to do about it? And on the next slide, you can see some of the things that we do have available to do about it. What we are trying to do with the treatment of Alzheimer's is avoid nursing homes. We are not going to turn someone with Alzheimer's into a rocket scientist. It is a progressive, deteriorating neurologic disease. You, at best, delay symptoms with some of the medications. The goal of the treatment is to go as long as possible before someone has to be institutionalized. Almost all of the clinical tests that have been done on the medicine, the main endpoint is not how long you keep your memory, it's how long do you stay out of an assisted living or a nursing home. So that said, these are by no means curative medicines. They are medicines to maintain quality of life as long as possible. So let's go on to the next slide, and we'll see what some of the options are. There are two main classes of medicine. The first medicine that was ever developed to effectively, or at least moderately effectively, treat Alzheimer's was known as Aricept. It's in a class of medicines called cholinesterase inhibitors. There's a chemical in your brain called acetylcholine. It is very useful at maintaining memory. But when your nerves talk, they use acetylcholine, and your brain doesn't want them to talk too long. It's kind of like a teenager on the telephone. You want them to just say what they're going to say and then stop talking already. So your body also has a chemical in it called cholinesterase. Cholinesterase destroys the acetylcholine. That way, one cell will talk to the next cell with the acetylcholine, but then the acetylcholine will get broken down so that there's a gap in talking and it's not a continuous conversation. It's so that you can have a thought, stop, go on to your next thought. Well, in patients with dementia and Alzheimer's, you oftentimes don't have a next thought. If you could at least hold on to the thought you're having a little bit longer, it would be a good thing. So what we've done is develop medicines that decrease the breakdown of acetylcholine so that with the limited number of nerve cells, because your brain has fewer nerve cells, those nerve cells that are still there can talk louder and longer and keep your memory at the maximum amount it can be, given that your brain has somewhat deteriorated. There are 3 medicines in the class, 3 main medicines. They are known as Aricept, which is a pill, Razodine, which is also a pill, and Exelon, which comes as a pill but is more commonly used as a patch. Sometimes a patch can be particularly good in patients with Alzheimer's disease because sometimes as their memory goes, they start to become obstinate and even times refuse medication. But it's easy to slap a patch on their back, and sometimes they forget it's even there and are willing to use it. There is an additional class of medicines which has just one medicine in it. That medicine is called Namenda. It tends to work very well in combination with the cholinesterase inhibitors to maximize how well the cholinesterase inhibitors work. Keep in mind again, the goal of treatment is not to improve memory. You are not going to, unfortunately, improve memory in almost anyone with Alzheimer's. What you are going to do is hold on to the mental faculties that you have for as long as possible and hopefully decrease the amount of time that someone has to spend in a nursing home or an assisted living going forward. So exactly how long are we talking about? How long can these medicines work? And on the next graph, I will show you. So these are patients who are put on Namenda versus not put on Namenda. There are similar graphs for Namenda plus Aricept versus without Aricept. But the end result is what you can see is 2 curves. The bottom curve is what happens if you don't use any medication. You can see that there is a pretty steady drop-off of memory. The top curve is what happens when you treat someone, in this case, with Namenda. It shows a slight bump upwards, but that's an almost inconsequential bump upwards. And then after, I would say, about 16 weeks on the graph, 16 weeks translates to roughly 4 months, you are then decreasing. And in fact, if you look, you are decreasing at the same rate as if you had never been on the medicine in the first place. In other words, when just using Namenda, according to this graph, what you do is you stabilize the memory for approximately 4 months before you continue or resume that fairly steep decline. Now you say, all right, so at 16 weeks, if you're going to be declining just as much as you would had you not been on the medication, why don't you just stop the medicine at that point? Because these are some pricey medicines. And the answer is you can't do that. The trade-off for 4 months of stable memory on Namenda is that you're on Namenda for life. Because you can see at 28 weeks, the person who took Namenda is still doing a whole lot better than the person who never took Namenda. The Namenda is holding on to those 4 months of increased memory. If you were to stop Namenda at, let's say, 20 weeks, by the time you got to 28 weeks, that person who took Namenda would be at exactly the same score as the person who had never taken Namenda. That person would accelerate their memory loss to catch up with the person who never took it. So even though the memory will continue to decline on the Namenda, you have to keep taking it because you're always going to be better than you would be if you stopped the medicine or than if you had never taken the medicine. If you use Namenda as well as a cholinesterase inhibitor, such as Aricept, then that 16 weeks goes out as long as possibly 52 weeks or maybe even a little longer. You basically can hold on to 1 year of extra memory, give or take, if you use the combination of Namenda plus a cholinesterase inhibitor. But again, you are on these medicines for life because if you stop them, your memory will fall dramatically within just a couple of days because you will fall to the level you would have been had you never been on the medication in the first place. Fortunately, the medicines don't have a lot of side effects. Some patients can have some stomach upset. Some patients can get a little dizzy. And on a couple of the medicines I've talked about, there can even be some increased aggressive behavior, which causes you to have to stop the medicine sometimes. But most people tolerate the medications quite well, actually. And when you're talking about losing the memories of the people you love and the things you love and losing the ability to live by yourself, a year for an 85-year-old with dementia, buying an extra year of being able to be at home can actually be a great gift. All right, let's go on to the next slide. Did you remember pen, eraser, and blue? Be honest with me. Did you? If you did, then you're probably in pretty good shape, at least for now. I chose this slide because it encompasses blue, pen, and eraser all in the same slide. It was hard to find a slide like that. But if you had trouble remembering the pen, eraser, and blue, maybe you should go talk to your doctor about getting a full mental status exam. In the meantime, keep your eyes open for dementia and memory loss, and a lack of ability to pay the bills, and even a loss of executive function in the people who are older that you love. And if you find that there's a decline, don't wait. Seek medical help immediately, because holding on to the memory is easier to do the earlier you catch the dementia. So, how can Activ Doctors help with the evaluation and treatment of dementia? Well, we have several solutions. First, our personal health records. They allow you to keep track of all of your records wherever you are, wherever you go. We can keep track of all of your mental status exams. Sometimes people slowly decline over time, and you want to know, has there been any significant decline that would cause you to rethink going on a medication? We could keep track of all of your mental status exams so that your doctor would have an easier time looking from one to another and noticing if there's been any significant decline. In addition, if your loved one moves into an assisted living or a nursing home, oftentimes they have to change doctors. And going through all those records for an 85-year-old can be next to impossible. So by having all of your records organized in one place, it's much easier for the new doctor to take control of your health care without losing any significant health information. With our e-consultation feature, you can discuss things with your doctor online if your doctor participates with our program. Sometimes when you have an elderly patient with dementia, it can be very hard to get to the doctor's office. So having access to an e-consultation feature can be very, very important and help maintain wellness when otherwise you would have said, nah, it's not worth going to the doctor over this because it's so hard. And finally, with our second medical opinion, if you or a loved one is having problems with memory or anything else, and you don't necessarily trust that the evaluation you're getting from your doctor is completely accurate, or just want to hear it from a world-renowned specialist on the subject, we can get you a second medical opinion in as soon as 48 hours, who can review your mental status scores, can review your CAT scans and MRIs in our system, and give you a top-quality second opinion that can help hopefully put your mind at ease. With that, I'm going to turn it back over to Caitlin to tell you how you can get started using Activ Doctors Online's medical system and online PHR, and how it could go about improving your health.
Thank you, Dr. Zahalsky. Here at Activ Doctors, our vision is to reinvent healthcare by providing user-friendly mobile health solutions that allow people all over the world to live healthier, safer, and more productive lives. We strive to educate, engage, and empower our members to really take control of their health destiny to save time, money, and in some cases, lives. We invite you to try Activ Doctors free for 30 days. Simply head over to our website, www.activdoctorsonline.com, and click Get Started on the homepage. If you would like more information about the webinar, would like to schedule a demonstration of our unique health platform, or have any questions about the services, please feel free to contact Dr. Zahalsky or myself directly using contact@activdoctors.com. You can also reach us on social media. Find us on Twitter @Activ Doctors and on Facebook and LinkedIn at Activ Doctors Online. Thank you, and please join us again next month for another informative health webinar.